Okay, good afternoon, one and all. I'd like to actually begin the presentation by saying that the debate on glucosamine in the treatment of osteoarthritis is still an ongoing one. Up till now, there's still no resolution with regards to this group of nutraceuticals and its benefits in the treatment of OA. Before I say that, before I go on to my next slide, I'd like to actually also say that this was actually, there was an insightful commentary written by Paul Dieppe, who's an eminent rheumatologist as well as an OA expert, several years ago, and I'd just like to quote from his editorial. And he said that we conclude that there is more confusion and hype about glucosamine than magic. The rationale for its use is unclear, the best dose and route of administration unknown, and the published trials do not allow for any conclusion about its efficacy. However, in its defense, it does seem to be a very safe compound, and any safe, effective compound for use for OA could do much good, even if the effect size is small. However, given the confusion, we cannot recommend its wholesale use. We need large clinical trials without company intervention. So that was then. Where are we today? Well, hopefully a little bit clearer on the picture. Before I carry on with the evidence, I'd like to just walk you through some basics about glucosamine and then update you on some evidence. Interestingly, it was actually first identified in 1876, and it is actually an amino sugar, which is an important precursor for glycosaminoglycans, which is an important component of cartilage matrix and synovial fluid. And as you all know, it is found in abundance in crustacean shells, arthropods, and even fungi. And that's why there's been in the market, if you might have heard from your patients, even vegetarian glucosamine, okay? Commercially, it's actually produced largely by the hydrolysis of crustacean shells. And how in the world does glucosamine work? And if you look at this slide, we still don't know up till today. The mechanism is quite unclear. What we do know initially was that it was rather simplistic to think that glucosamine, being a building block, would actually promote cartilage synthesis. But in recent years, there's been developments in the work in this area, and there's found that if you actually stimulate chondrocytes with glucosamine, it actually suppresses gene expression of cartilage. So glucosamine actually in vitro does the opposite. And recently, there's been several publications, very nice studies that actually show that very little of what we ingest actually gets into the joint. Levels 500-fold lower are assayed in the synovial fluid than that required to actually modify chondrocyte activity. So in other words, glucosamine probably doesn't work by stimulating cartilage synthesis. Interestingly, though, rather intriguing, researchers have found that in the synovial fluid, after a patient ingests glucosamine, there is a persistent, sustained low level of glucosamine that's detected in synovial fluid. And this has led to a second postulate, which is that instead of this cartilage synthesis theory, glucosamine actually may have biologic effects, such as inhibiting cartilage degradation enzymes and also other inflammatory properties. But this is a work in progress. Finally, to the heart of the matter, all of you have your CPG guidelines, which actually state the level of evidence as well as our recommendations. The work group looked through all the published data and appraised it systematically, and the results are actually very disappointing. The bottom line is that neither glucosamine or chondroitin has been shown in an evidence-based manner to be more efficacious than placebo in the treatment of knee OA pain. I will just want to walk you through two important studies that have come out in the last 2 years with regards to this, and the first being the Cochrane review that was published in 2005. And this is a systematic review and meta-analysis of 20 randomized controlled trials. And the sad thing is that the results are really not uniformly positive. When the 20 RCTs were analyzed according to the Leakine Index for outcomes of pain and functions, glucosamine appeared superior, was significantly superior. But however, when these patients were assessed using the WOMAC outcomes, which is the Western Ontario and McMaster University outcomes, which are rather worldwide accepted outcomes for measurement of OA function and pain, there was actually no significant improvement in terms of pain and function with glucosamine. And they went on to actually analyze the analysis to 8 randomized controlled trials which had adequate allocation concealment, and this again failed to show benefit of glucosamine over placebo. And finally, I'd like to also highlight to you that these findings were actually discrepant when the authors actually looked at the rotor preparations for glucosamine. They found that of the 10 RCTs, rotor preparations of glucosamine actually demonstrated superiority as opposed to the pooled analysis of the non-rotor preparations, which didn't show any benefit. So why all this confusion? I think it all boils down to the fact that really all the trials were heterogeneous. There were differences in the subjects enrolled, differences in the types of outcomes evaluated. The methodological quality was also suspect in some, and various trials allowed varying degrees of co-intervention. For example, some allowed Celebrex, some allowed paracetamol, so it's hard to really compare them equally. And finally, also the fact that different preparations were used. And that brings me to the next trial, which I like to highlight, which is the GAIT trial, the Glucosamine Chondroitin Arthritis Intervention Trial, the results of which were published in the New England last year. Why is this GAIT trial important? Because it is actually to date the largest non-pharmaceutical-driven study on glucosamine. But unfortunately, the GAIT trial took a different turn. They decided to use glucosamine hydrochloride rather than glucosamine sulfate, which was the most commonly investigated product and most common product in the market. So the results of the GAIT trial were unfortunately negative as well. There was no overall benefit over placebo for outcomes of pain and function. However, in this group, the subgroup analysis did reveal that those with moderate to severe OA pain may benefit from a combination of glucosamine hydrochloride and chondroitin sulfate. The next question patients may ask you or come to see you for is, doctor, can I take glucosamine to prevent OA because my mother has very bad OA? Or, I'm a runner, I'm an athlete. Can I take OA to prevent my joints from wearing out faster? Well, the answer to both questions is no. There's unfortunately still no evidence to suggest that there is any use of it in primary prevention. And also, the earlier studies which purported that there was some degree of structural modification with glucosamine have been actually heavily criticized because of the way the X-rays were taken. But watch this page because the GAIT investigators are looking at the effects of glucosamine on structural modification, and the results will probably be out towards the earlier half of next year. Finally, should we recommend glucosamine is probably the question most of you would ask, and I ask myself. I think the important take-home messages are these. Glucosamine is really an over-the-counter product, so you can't stop your patients anyway. It is hence not subject to stringent manufacturing regulations. And as many varieties there are in Heinz baked beans, there are that amount of variations in the active ingredients in glucosamine. And hence, the results that I presented today are not really generalizable to all the products that you have from GNC, et cetera, So one has to be very careful as to when you share this evidence with patients. If your patients have failed or did not find sufficient response with all the non-pharmacologic measures as well as pharmacologic therapy and want to try glucosamine, well, most certainly they can because it is a safe product, but recommend glucosamine sulfate and add a dose of 1,500 milligrams once a day. Don't split the doses up because at 1.5 grams a day, taken once daily, ensures a most optimal penetration into the synovial fluid, and that's what you want. And if patients don't respond at all after 3 months, you can actually recommend that they stop it. After all, it is fairly expensive. And finally, what do we say to patients who actually have some benefit with this drug? Well, if they have benefit, the evidence suggests that after 6 months, you can actually tell your patients, look, why don't you take a holiday, stop the glucosamine, because the evidence suggests that if you, beyond 6 months, the benefit of glucosamine in terms of reduction of pain is the same as placebo. With that, I'd like to thank you.